Good morning, everybody. This is Hugh Hagan. I'm a member of the section of hand surgery at Carilion Clinic Orthopedics in Roanoke, Virginia. What we're going to discuss today is hand surgery and tetraplegia. I have no disclosures. Good review references for this talk are found on the American Society for Surgery of the Hand website, ASSH.org, in Handthology and in Hand E, both of which have video references, written references, articles, all easily accessible. And I would reference this as your best source of information for the subject covered today. An outline of today's talk includes epidemiology of tetraplegia, how to pick your patient for surgery, and classification and treatment, which is based upon intact functional level and patient needs. And these include the surgical options of tendon transfer, tenodesis, fusions, and possibly nerve transfer. The take-home messages from this talk include tetraplegia reconstruction is underutilized nationwide. Surgical treatment includes tendon transfers, tenodeses, fusions, and in some cases, perhaps nerve transfer. We'll look at the International Classification for Surgery of the Hand in Tetraplegia and the priorities for surgical reconstruction, which include elbow extension, wrist extension, key pinch, finger and thumb extension, which is capture and release, and finger and thumb flexion, which is also defined as grasp. In the United States, there are over 100,000 tetraplegics, and the tetraplegia resulted from trauma, tumor, and infection. 3/4 of these would potentially benefit from some form of upper limb surgery to improve upper extremity function. 2,500 cases could be done each year, and that's a conservative estimate, but actually far fewer cases are done every year, less than 400 in all the years examined. So, who should get operated on? What are we operating on them for? When do you do it? And where and why? Who gets operated on? Well, it has to be the tetraplegic patient with motivation to get well, who has achieved neurologic stability from their injury or other pathology, whose associated conditions such as open wounds, spasticity, and infections are under control, who has at least grade 4 motor function in the donor muscles, and who has adequate sensation and pain control. And finally, absence of joint contractures. In managing these patients, you want to work closely with ancillary providers and your community if possible, including physiatry and hand therapy. You want to pick procedures that will improve function in your particular patient. You want to perform these procedures as soon as possible. And when you do tendon transfers, you want to do a sound connection between donor and recipient tendons. This can be a woven transfer or a good side-to-side transfer with at least 5 centimeters of overlap. Solid tendon transfer allows early rehabilitation. When do you do it? Prior recommendations advise waiting 12 months for neurologic stability to be achieved, but more recent data suggests that complete lesions are not going to show enough improvement after 6 months to change your treatment options. So the sooner the treatment begins, the less trouble you'll have with joint contractures, muscle end plate deterioration, and loss of motivation by the patient. Local infrequency and emotional impact of this problem can delay care. And I would say in nearly 40 years of community practice of hand surgery, I've only cared for a handful of these patients. So it's relatively infrequent in any one community that any one surgeon has a particular experience-based expertise in taking care of these patients. It is better, however, to provide simple, reliable treatments as soon as you possibly can than let the patient get lost in the system. Most hand surgeons in practice can perform an early, skillfully done procedure with good postoperative OT and physiatry support, familiar operations such as tendon transfers and fusions that will allow a patient to get up and off the ground with long-term training and reintegration occurring in a regional spinal cord injury center. So why are there these delays? Well, in spite of the favorable outcomes from simple procedures that can be performed by most hand surgeons, many tetraplegic patients are just not referred for upper extremity care. So it's important for hand surgeons to communicate with physiatrists and therapists and let them know that these options are available and available in their communities. So you want to educate your medical community. If you're interested in taking care of these patients, get out and tell the people with whom you would work what you can offer these patients early on. So the goals of treatment include recovery of hand function, which outweighs recovery of any other activity daily living, according to patients with tetraplegia. This includes bowel and bladder control, sexual function, and ability to walk. Recovery of hand function, especially elbow extension, leads to increased independence. And this is the most important thing for these patients, not being dependent on others for everything. Eric Moberg said that you want to maintain a supple hand for human contact, that you want to strive for simplicity in achieving operative goals, familiar operations with well-trained hand surgeons. And when you don't have much, a little bit means a lot. So doing simple procedures can make a tremendous difference in day-to-day life and function for these people. Major functions to restore include elbow extension, wrist extension, pinch, hand opening, which is capture and release of objects, and hand closing, which is grasp. Surgical techniques that we use include tendon transfers, tried and true, tenodeses, fusions, and in some cases, nerve transfers. This is a relatively new approach towards tetraplegia in some centers, and some promising results have been reported. You want to refer to the Medical Research Council grading for motor strength, which goes all the way back to 1943, but we're all familiar with this. The M0 muscle has no contraction, M1 a flicker, M2 active movement with gravity eliminated, grade 3 active movement against gravity, grade 4 active movement against gravity and resistance, and grade 5 is normal. And when you're doing a tendon transfer, you only want to use donor muscles with grade M4 or greater. Level of injury classification. There are several systems that have been put in place to describe the level of spinal cord injury. Generally, they're all based on the lowest functioning cord segment. It requires a very careful physical exam and likely several visits to be sure of the physical findings. The assistance of occupational therapy and hand therapy in evaluating these patients is also critical, as they can provide additional information with subtleties of function that may not be easily seen on a routine physical in the clinic. Operative planning. You want to make a list of muscles the patient has as donors, grade 4 or better. You want to make a list of what muscles are available for transfer. In other words, you don't want to eliminate function that cannot be duplicated by another muscle. You want to make a list of what functions the patient needs, and then you consider tenodeses, arthrodesis, or nerve transfer as ancillary procedures to your tendon transfers. What about nerve transfer? Well, there are techniques that are evolving with clear potential in tetraplegic patients. Bertelli in 2011 and Van Zyl in 2014 both reported successful results with nerve transfer in small groups of patients with tetraplegia. Bertelli used the teres minor branch of the axillary nerve to the triceps to achieve M4 triceps at 14 months, and Van Zyl did the same, plus the brachialis branch of the musculocutaneous to the anterior interosseous to achieve finger flexion, and the supinator branch of the radial to the posterior interosseous nerve, or spin procedure, to achieve finger extension and thumb extension. Of these procedures, the one that has been used the most has been the spin procedure. The brachialis branch of the musculocutaneous to the anterior interosseous has not been shown to be as reliable, and also can potentially eliminate elbow flexion by denervating the brachialis. Nerve transfers have a positive and a negative feature as well. On the positive side, they really require nothing in terms of postoperative occupational therapy other than maintenance of passive motion and preservation of flexibility. So they're easy in that regard. On the negative side, it takes a long time for them to work, and most of these will not be working any sooner than about a year. So the considerations of ease of the procedure and ease of postoperative therapy are perhaps overridden by the delay in recovery of function, such that the supinator branch of the radial to the posterior interosseous can be considered in addition to tendon transfers to restore finger and thumb extension, but perhaps is not the ideal procedure as an isolated procedure to achieve that goal. In spinal cord injury, at the level of the injury, the anterior horn cells are injured, and their muscles distally are then denervated. The reflex arc is broken, muscles are denervated and will atrophy. The motor end plates will atrophy, and you only have a certain amount of time before you cannot reinnervate these muscles, anywhere from 18 to 24 months. Above the level of the spinal cord injury, the anterior horn cells are intact and the muscles have volitional control, so these are potentially good donors. Below the level of the injury, the anterior horn cells may well be preserved, uninjured, and viable. Thus, the muscle downstream remains innervated, and nerves are potentially good recipients. Nerve transfer can take advantage of this intact motor circuit below the level of injury. The appropriate surgical candidate. Well, the candidate with neurologic stability, 6 months or so post-injury, medically stable, grade M4 or at least donor muscles are available, adequate sensation or protective sensibility and control pain help, the absence of joint contractures and control of spasticity, and perhaps most importantly, motivation and cognitive capacity. And this means getting on with the treatment as early as possible while the patient has the drive to try and achieve functional improvement. This graph shows some familiar relationships between the level of innervation and the function preserved. This graph is available on the American Society for Surgery of the Hand website. Let's look first at the C5 cervical root. What does it do? It's responsible for elbow flexion through the biceps and brachialis innervation, and supination through the biceps and the supinator branch of the radial nerve. The C6 root is responsible for wrist extension. The C7 root is responsible for elbow extension, finger and thumb extension, and wrist flexion. The C8 root is responsible for finger flexion. And T1 intrinsics. Another way to look at this is by looking at a diagram of the brachial plexus. This demonstrates gross motor function at each spinal cord level. In general, the upper roots innervate the proximal extremity and the lower roots the distal extremity. C5 is responsible for shoulder abduction and elbow flexion through the axillary nerve and the musculocutaneous nerve. C6 is responsible for wrist extension. Radial nerve. C7 is responsible for elbow extension, finger extension, and wrist flexion through the radial nerve. The median nerve. C8 is responsible for finger flexion through the median nerve and the ulnar nerve. And T1 is responsible for intrinsic innervation through the ulnar nerve. So when you're planning your surgery, you want to prioritize the functions you're trying to restore. Keep coming back to this. First priority is elbow extension. The second, wrist extension. The third is pinch, specifically key pinch, which is the pulp of the thumb against the radial middle segment of the index finger. The fourth is capture and release, in other words, the ability to open the hand. And the fifth goal, grasp, the ability to close the hand. So in looking specifically at tetraplegic patients, there's a classification system, the International Classification for Surgery of the Hand in Tetraplegia, which describes which muscles function below the elbow. Individual muscles must have a Medical Research Council grade M4 or greater to be considered functional. Groups are numbered based on the number of functional muscles or muscle groups below the elbow. This graph demonstrates the International Classification for Surgery of the Hand in Tetraplegia. You can see here in a group 0, there is no muscle below the elbow suitable for transfer. The function that's retained is flexion and supination of the elbow through the biceps and the brachialis. In a group 1, you have brachioradialis with forearm neutralization. In a group 2, you have two muscles, brachioradialis and ECRL. Preserved is weak wrist extension. In a group 3, brachioradialis, ECRL, and B, which now has strong wrist extension. In a group 4, you add pronator teres, which improves pronation of the forearm. In a group 5, you add the FCR, which preserves flexion of the wrist. In a group 6, you add the finger extensors, or extrinsic extension of the fingers. In a 7, the thumb extensor. In an 8, the digital flexors. And in a 9, the digital flexors, which are stronger, and you're lacking only the intrinsic muscles. So let's look at each group quickly and to try and understand the logic behind how these patients can be managed. In a group 0, there is no muscle below the elbow that's suitable for transfer. What's retained is flexion and supination of the elbow and forearm, but no muscles below the elbow are functioning. So what do you try to do here? You want to get elbow extension. Elbow extension transfers are critical to the function of the hand in the tetraplegic patient. The ability to extend the elbow really increases the functional capacity of the hand as a helper. It allows patients to transfer, shift weight, work a manual wheelchair. There are a variety of things that can be done with intact elbow extension. There are two transfers that have been described to achieve elbow extension. 70% of tetraplegic patients will lose elbow extension. The elbow extension, as I've said, improves mobility, and it increases the workspace of the hand by 800%. Performed include, most commonly, the biceps to triceps and the posterior deltoid to triceps. The posterior deltoid to triceps requires a tendon graft to attach the distal portion of the middle third of the deltoid to the triceps tendon distally. It is a functional transfer, but it requires a long period of immobilization to avoid stretching out your tendon reconstruction. The biceps to triceps transfer is more commonly used now, as it does not require tendon grafting, and it is a direct tendon to bone attachment. Here's a drawing of harvesting the biceps. You must have preserved brachialis and supinator function in order to transfer the biceps. If you transfer the biceps, the functional biceps, with no function of the brachialis or supinator, you lose elbow flexion. You mobilize the biceps for a straight line of pull, which is a fundamental in tendon transfer. You transfer around the medial side of the arm and under the ulnar nerve to avoid nerve compression on the ulnar side. Nerve transfers, which can be considered, include the axillary nerve branches to the radial branches of the triceps. Group 1 has one remaining functional muscle, which is the brachioradialis, which, as you will see, will be a workhorse for the tetraplegic patient. With the brachialis working and the elbow extension intact, then you want to improve wrist extension via tendon transfer, and you want to improve pinch via tenodesis. There are braces that are used to improve pinch, but they are somewhat bulky. They require an active wrist extensor, and they haven't been well accepted by patients because of the bulk and difficulty putting them on and off. Surgical approach includes wrist extension transfer, taking the brachioradialis tendon to the central wrist extensor, the ECRB. And then Moberg's key pinch procedure, which we'll discuss in a second, which includes stabilization of the thumb IP joint. The spin procedure can be considered in this setting, but once again, it's a timing issue. It could be added to the transfer of the brachioradialis and the key pinch procedure, but you wouldn't expect it to activate for some period of time. Tenodesis for pinch, or the key pinch procedure as described by Moberg, includes brachioradialis to ECRB, which gives you active wrist extension, and tenodesis of the thumb flexor to the distal radius volarly. In an effort to prevent IP flexion and thus create difficulty with key pinch, you want to stabilize the IP joint of the thumb. And Moberg described this simply by using a K-wire. More commonly nowadays, a split distal flexor pollicis longus transfer is performed. Specifically, half of the FPL is left attached volarly. It is split, and the other half is attached to the terminal tendon. So it balances flexion and extension and avoids a hyperflexed IP joint. Group 2, there are now two muscles working. The ECRL is added to the brachioradialis. The preserved function is weak wrist extension with radial deviation. Your goals remain improving key pinch and improving thumb extension, because now you have wrist extension. And this is accomplished by tendon transfer, fusion, and tenodesis. The tendon transfer, as before, brachioradialis to FPL. You fuse the CMC joint of the thumb and palmar abduction. You stabilize the thumb IP joint, as noted before, with a wire or split FPL. And you tenodese the extensor pollicis longus to the forearm fascia, such that when the wrist is flexed, the thumb will extend through the tenodesed extensor pollicis longus. The spin transfer can be considered. Group 3, the ECRB is added to the muscles that function. And this means now you have strong central wrist extension. Having the ECRB functional will free up the ECRL for transfer. And keeping in mind what your goals for reconstruction are, which include elbow extension, wrist extension, pinch, grasp and release. And the goal here is to provide active finger flexion, and this can be done by transferring the ECRL to the finger flexors. If you're not sure about the function of the ECRB, then you just simply test the strength and make sure that the patient isn't radially deviating excessively when they extend their wrist. And you look for a physical finding referred to as Bean's sign, which is the groove that presents between the ECRB and ECRL when the wrist is forcefully extended. The ECRB now provides strong wrist extension. So as before, brachioradialis to FPL and ECRL to FDP of the index through ring. You don't want to include the small finger flexor in the transfer. because the flexion on the ulnar side of the hand will overwhelm flexion on the radial side of the hand. So the index, middle, and ring are included, and they are done in a reverse cascade, such that the index finger is a little tighter than the middle finger, which is a little tighter than the ring finger. And then stabilization of the IP joint of the thumb, so you don't end up with a flexion deformity of the terminal thumb IP joint. You include the CMC fusion to place the thumb in palmar abduction. And you tenodese as before the EPL to provide tenodesis extension of the thumb when the wrist is flexed. The spin nerve transfer can be considered. In group 4 and group 5, which are handled in a similar fashion, you add the pronator teres and the flexor carpi radialis to the functioning muscles, which means you now have preserved some extension and pronation of the wrist and flexion of the wrist. Your goals here include thumb and finger extension, improved finger and thumb flexion, CMC stability of the thumb, and this is accomplished by tendon transfer and tenodesis, brachioradialis to FPL, ECRL to FDP of 2 through 4, as noted before. Once again, stabilization of the IP joint of the thumb. Consider intrinsic balancing with free tendon graft tenodesis, fusion once again of the CMC joint, and EPL tenodesis to the forearm fascia, considering a spin transfer. In group 6 and group 7, you now have the common digital extensors and the thumb extensor functional and preserved. Your goal here is to improve thumb and finger flexion. Your EDC and EPL are now functional, so you do not need to do a nerve transfer or tenodesis of extensors to improve finger extension. You need to improve thumb and finger flexion. Once again, the ECRL can be transferred to the deep flexors of the index through ring and the brachioradialis to the FPL. These are familiar transfers from previous groups. And in group 8, you have intact digital flexors partially. So your goal here is to get stronger finger and thumb flexion. Suturing the FDP side to side 2 through 4 will take advantage of increasing strength radially. You want to balance them to avoid inadequate index and middle finger flexion. Once again, the fifth finger flexor is left out and you put it in a reverse cascade, and there's the mighty brachioradialis allowing the thumb to be flexed. And in group 9, you are lacking only intrinsics. You have strong finger flexion, so your goal is to try and restore some intrinsic function. This includes MCP flexion and IP extension of the fingers and extension of the thumb IP joint and flexion of the thumb MP joint. Thumb intrinsic reconstruction includes a split FPL to balance the IP joint, and then improving pinch strength by transferring the ECRB to the adductor pollicis, generally using a graft through the third web space. For finger intrinsic reconstruction, you want to remember that the intrinsics flex the MP joints and extend the IP joints. That's the basic function you're trying to restore. So you perform this physical exam technique called Bouvier's maneuver, where you passively flex the MP joints and see if the IP joints will passively extend. If they do, then you are safe to perform a procedure that will actively flex the MP joints, knowing that this will allow the IP joints to extend via tension on the extensors. The Zancoli lasso procedure is a straightforward procedure which improves active MP flexion. The flexor digitorum superficialis is released from the base of the middle phalanx and then transferred through the A1 pulley, making it an MP flexor instead of an IP flexor. blocks MCP hyperextension, and allows for active PIP extension via the extrinsic extensors. The patient-reported outcomes of surgical management of tetraplegia are pretty good, with about 3/4 being satisfied, positive impact on life, positive impact on independence and activities of daily living, particularly with elbow extension, and positive response when asked about employment-related factors. Patients become far more independent. They can drive, they can get a job, they can get out of their house. So the take-home messages here would be tetraplegia reconstruction is underutilized. Be familiar with the International Classification for Surgery of the Hand and Tetraplegia. Think of the priorities of reconstruction, which include elbow extension, wrist extension, recovery of key pinch, finger and thumb extension, which is capture and release, and finger and thumb flexion, which is grasp. Surgical options include tendon transfer, tenodesis, and arthrodesis, as well possibly as nerve transfers. Strive for simplicity in achieving these operative goals. Thanks very much for your time.